At this time, I'd like to introduce you to our speaker, John Gale. Since joining the University of Southern Maine's Rural Health Research Center, rural hospital and delivery system issues have formed the core of Mr. Gale's research. His work concentrates on the operation of rural delivery and safety net systems involving critical access in other rural hospitals, rural health clinics and primary care providers, and substance use and behavioral health providers. He has conducted numerous studies on the prevalence of rural substance use, including opioids, substance use delivery systems, and strategies to address rural substance use. He serves on the Board of Trustees of the National Rural Health Association and New England Rural Health Roundtable. He is the Senior Fellow of the Health Research and Educational Trust of the American Hospital Association and an adjunct member of the Public Health Program in the University of New England College of Graduate and Professional Studies. He recently completed a Rural Substance Use Prevention and Treatment Toolkit for the United Nations to support policymakers in developing countries. Now I will turn it over to John. And John, if you muted your number, it's *2 to unmute. Let's see here. Looks like John is typing. Just a moment. Oh, John is just calling back in again. While we wait, if you haven't already filled out the before poll questions, poll 1, concerning my knowledge of prevention, treatment, and recovery with opioid and other substance use, I am. And if you could just fill out if you're unfamiliar, slightly familiar, moderately familiar, confident, or extremely confident. The second poll is concerning your knowledge of strategies to implement and address substance abuse. So we're just going to give John just a moment here as he calls back in. And again, the slides for today's webinar can be found on the bottom left-hand side of the screen by clicking Download Slides.
Hello, this is Kim. Can you hear me now?
Yes, I certainly can.
Disconnected, so I apologize.
That's okay. Take it away, John.
Thank you. Welcome, everyone. What I'd like to do today is really talk to you about what role hospitals and rural hospitals can play in substance use in their communities. I think it's an incredibly important topic, and I will focus primarily on opioid issues, but also recognize that much of what I'm saying applies to other substances. So before I go too far, I do want to thank the Federal Office of Rural Health Policy for the support of our center, which has enabled me to do this work in this area. So my brief learning objectives, I'm going to introduce you to rural opioid and other substance use issues, talk a little bit about the drivers and what contributes to rural opioid and substance use, why hospitals should be engaged, and talk really about a system of care, because I think that's incredibly important. Talk about the importance of engaging the community, and then we will review specific strategies used by communities and critical access hospitals in their to address this problem. Now, what I want to do up front, and I try to do this often, is to give you the takeaway messages so you can be alert for them, and in case I bore anyone to tears, they've at least heard the important points. So, you know, we talk in rural health about The one phrase that you've all heard is, if you've seen one community, one rural hospital, one rural clinic, you've seen one rural clinic. And I want to call foul on that one. Yes, each community has its own resources, but the common factors that contribute to substance use and are very common, and they can be addressed. Each community may have a different type of substance use. In some communities, it might be prescription medications. In others, it can be heroin. In almost every community, it's alcohol. So while their problems may differ, the solutions can have some common features, and I think it's really important to remember that. It also takes a village. The hospital, any hospital acting in and alone, is not going to have the impact that working as a community and involving all the central players will. I think they can have a central role and certainly a leadership role as the hubs of the healthcare systems in their communities. But some of the reasons why the hospitals should think about this is, really I think the leadership role is critically important. But also for those 501c3 hospitals and public facilities to satisfy their community obligations. Tax exempts have community benefit requirements and community health needs assessment obligations. And publicly owned facilities have a responsibility based on their tax benefits and in some case tax funding they get from the municipalities and counties. I think the other piece is that it's an important population health issue, and almost every community, and I would dare say very few of us on the phone, have not had someone in our lives, either family members, friends, ourselves, that have been impacted by this issue. And finally, there are models that are out there that make a lot of sense. But they've got to be adapted to the geographic and the resource and cultural realities of communities. So I'm going to talk to you about the three basic strategy areas and go into them a little more deeply. It does us little good to treat substance use if we aren't trying to reduce the prevalence. And the good news is that prevention works, prevention is cost effective, and there are a number of models that we can look at. So within the whole idea of the opioid issue, which is on so many people's minds, it's important to realize that opioid harms extend to all users, not just those who are using heroin, which is an illicit drug, or misusing prescription medication. There are many, many people who are taking opioids under physician and provider orders that are suffering some of the same harms of overdose, addiction, and other problems. So it's important to remember that. Our goal in prevention is to discourage, when we can, the use of illicit drugs and other substances, or in some cases for those legal substances such as alcohol, or now in some states marijuana, delay the onset of use so that younger people are starting to drink or they're delaying the start of their substance use behavior. Our focus really should be on children, adolescents, and young adults. Part of the strategy is also to minimize related high-risk behaviors, drinking and driving, getting arrest records and legal problems, domestic violence. So can we use, and prevention does contribute to reducing these issues. They should be external and community-focused for many of them, and that really involves community organizing and education, but the internal activities where the hospitals have a direct role really relate to things that they control directly, which is reducing their contribution to the supply of opioids and other prescription medications that are prescribed. And there are great strategies we'll talk about. Prescribing guidelines, increased use of prescription drug monitoring program, expanding access to alternative pain management strategies, and providing opportunities to dispose of unneeded medications. Strategy 2 is treatment, which I think many people immediately jump to when we start talking about substance use. It's really helpful if providers begin to implement consistent screening for opioid and substance use disorders across patients. There's the SBIRT program, screening, brief intervention, referral to treatment, but there are many, many tools out there that can be used. Developing referral relationships with substance use and mental health providers. Looking at opportunities to expand treatment. We've all heard about buprenorphine, and medication-assisted treatment as a way of helping people with opioid use disorders control their cravings. But it also may mean integrated behavioral health, substance use, and primary care services, and developing some specialty substance use services. I've heard of some hospitals recently that are interested in using excess beds for detox for people who
John?
are... Yes.
I'm sorry to interrupt. Some people are having trouble hearing you. Could you speak just a bit louder?
Sure. I'm sorry. Is that better?
Yes, that's so much better. Thank you.
Okay, I apologize. And actually working with law enforcement to provide an alternative to incarceration. And we'll talk about Project Angels and Project Hope and other things that are out there. And the last strategy, and this is the one that I think many people tend to overlook, is recovery. It's part of the 3 legs of the stool of addressing substance use and opioid use disorders in the community. It's a way of providing an opportunity for people to change the circumstances of their life that supports sobriety and substance-free living. And ideally, it begins before treatment, because that support is necessary as that support is necessary before someone goes through and engages in treatment. And we'll talk about some models shortly. So let's touch base very, very quickly about rural and opioid and substance use in these states. If we look at the national statistics and overall rates of substance use across urban and rural populations, they do tend to be very comparable, and because we're looking at it at a broad population basis. But when you start looking at the community level, at the county, at the subpopulation level, it's where we begin to see variations. So some of the things that we've observed in our work is that past year alcohol use, OxyContin, which is a prescription opioid, and methamphetamines, and the use of these 3 drugs is higher among rural youth. Rural 8th graders are more likely to have used amphetamines, crack cocaine, marijuana, and alcohol than their urban peers. Rural youth drink and experiment with alcohol at a younger age, and they're more likely to drive under the influence. And opioid use is higher among youth, rural youth, young adults, women experiencing domestic violence, and in states with large rural populations. And one statistic, which I suspect many of you have heard, is that our opioid deaths are growing much faster in rural communities, and in many states like West Virginia, the number of opioid overdose deaths exceeds the rate of deaths due to car accidents, which is a frightening statistic. So here are some of our drivers of substance use as we think about this. So socioeconomic status, poverty, lack of education, unemployment, lack of opportunity are a big issue. We have neighborhood factors, which can include just attitudes about substance use. Alcohol is a particular problem. most of us know it as a legal and well-advertised substance that many adults will participate in, but the level of tolerance for alcohol use, especially among young people, varies, and it can be quite high in some rural communities. Social disruption and change, loss of jobs, loss of opportunities, and in some places violence or natural disasters that upset the social order contribute to substance use, and then which includes some things like environmental offense. If you look at the flooding in the southern states and the fires out in California, that disruption does increase substance use, and particularly in rural areas. Some of our barriers to treatment, not uncommon with many issues. We have fewer facilities. In rural communities, we have geographic barriers. It was not uncommon to hear of rural people having to drive 2 to 3 hours each way to obtain methadone for opioid use disorders. Methadone is typically only prescribed on a daily basis, and so they would end up spending 4 to 6 hours a day in a car just to get the medication they needed. We have less anonymity. It's hard to hide in a small community if you've been in trouble with the law and other people due to substance use. That stigmatization, criminalization, we tend oftentimes to look at, especially opioid use and illicit drug use disorders, as a criminal behavior rather than as a chronic relapsing disease. We have no public transportation and few treatment professionals. Just as a quick piece to give you an idea of the things that we're talking about, and you may be surprised at how the things that fall into this category, most of us understand alcohol and the illicit drugs, including the redirection and misdirection of prescription medications. Certainly opioids are big in the public news at the moment, but the other category of prescription medication, benzodiazepine, mood stabilizers like Valium, are right behind it, opioids, as the huge issue. And then the over-the-counter drugs, cough medicines, cold medicines. I visited a community in Alaska where inhaling gasoline was the primary problem. So you, again, looking at what's going on in your community really is important. So you need to think broadly about what the substance use problems are. We talked a little bit about the drivers of substance use. I won't go into them too much, but we've already talked about them. But influence of cultural and ethnic and religious differences need to be considered as well. We touched on this briefly, but why should hospital engage in and be involved in opioid and substance use? As we've mentioned, the problems aren't related to the opioids and substance use disorders, but they trigger many other health and safety problems. People who are misusing substances or have a substance use disorder are likely to use more physical health resources than those that are not. We know that many people treated in emergency departments have an opioid use disorder and are on life, and it's oftentimes not recognized as part of the problem. There are economic consequences if you look at family disruption, loss of income, and the costs of long-term substance use. We've talked about their opioid use disorders. I'm sorry, I will try to speak up. Rural hospitals, and the other piece is that it's a leadership issue, and rural hospitals can play an important and effective role. They're ideally positioned. And we should look at a public health model, which really gets at a community, which gets to the community organizing factor. We have you need systematic data collection, which can be done at a community level on the scope and characteristics of substance use, thinking about the factors that may drive it, how partners collaborate and engage to address some of these issues, deciding what the prevention and treatment interventions are. There may be multiple problems going on in a community, and there are only so many resources, so prioritization is critical. Monitoring the impact of interventions on substance use. How well is the intervention working? Does it need to be changed? And then that community leadership is really very critical. So it's a comprehensive approach. It's a community-based approach. There are evidence-based treatment services, prevention services, and recovery programs that we'll talk about very quickly that can be adopted and can be done at a fairly cost-effective level. Let's move into prevention. There's very strong and well-supported scientific evidence that prevention works. And it's that simple. These programs are not necessarily out of the reach of any community. They can be done with a focus and collaboration. They can effectively prevent initiation. They can reduce harm and minimize related problems. We find that prevention is also cost-effective. Its return exceeds the expense at all stages of the lifespan, from infancy to adulthood. And what we need to think about is that each community and each population has different levels of risk protection and substance use disorders. It's important, I think, to understand that many of our communities it's not just a negative problem. I know we all have issues, we have resource constraints, but every community also has its own level of assets, and I think it's important to understand from a community organizing basis how to tap into those. So I would recommend that hospitals, as part of this, think about incorporating it into their community engagement strategies, looking at community coalitions that can assess local risk factors and implement the evidence-based preventions that really align with local priorities. It's primarily about healthy and safe development of children and youth. It helps them to realize their talents, and certainly preventing a young person from engaging in substance use disorders is certainly more cost-effective than treating them down the road. And as we mentioned, the goal is either prevention entirely or delayed initiation. And it also contributes to the positive engagement of children and young adults in their families, schools, and workplace. As people move into substance use disorders, not surprisingly, family relationships deteriorate, children do less well in school, and it creates a self-perpetuating cycle that continues to make the problem worse. So I think it's important to talk and to consider activities that can engage communities. Certainly how we engage and organize is important. It's important to look at prescriber education and behavior. As much as this opioids in particular are a big issue in the news, not all prescribers are doing well with modifying their behaviors. We need supply reduction and diversion control in many communities, it's nigh and impossible to dispose of unwanted medications. We need pain patient services and drug safety, drug treatment and demand, harm reduction. That includes things like needle exchanges. It includes the use of naloxone, which is the overdose prevention program. It can involve things like community transportation. I think in Portland we call them tipsy taxis for a while so that folks wouldn't drive under the influence. And then education that helps people understand the problems. So here are 3 community-based organizing models that we'll talk a little bit more about. The first, many of us have heard of, and the evidence base is very solid, is Project Lazarus. It was founded in Western North Carolina, and it was developed by a hospice director, also a minister, who was finding it difficult for his hospice patients to obtain appropriate levels of pain management because of all the issues with overdose deaths. It's become effective enough, and they've produced toolkits that are available on their website around community organizing that I'd encourage you to look at. That through the Reynolds Foundation, it was expanded to all North Carolina counties. Now, some are more effective than others, but it's gotten a substantial foothold. And it's taking place and it's being used across the country in rural communities. There's a project, Bald Eagle, in Williamsport, Pennsylvania, which I believe was the 2015 Rural Health Program of the Year, nominated and recognized by the State Rural Health Association. There's Project Vision in Rutland, Vermont, which is a collaboration between the police department and the state community government and social service agencies. This one has been fascinating. Rutland was a mill town on the Vermont border that sits on one of the main heroin trafficking routes from Montreal down to New York and Boston. And they had whole neighborhoods that were being decimated, and the local police department have really adopted this drug market intervention model to take back some of those communities, and we'll talk about that a bit more. SAMHSA, the Substance Abuse and Mental Health Services Administration, has recovery-oriented systems of care and the communities of care models that can be used. And I should say that if you have difficulty finding any of this information, I can share with Kim and all of you at a later point a series of links to each of these programs. So some of the key elements, and I think someone's still having trouble hearing. I'm hopefully we can. That's been resolved. But some of the key elements of effective community coalitions is really understanding local need and issues, developing through communication, through shared planning, a comprehensive vision, developing a complete, clear and focused strategic plan, having diverse members, not just community leaders and healthcare providers, but local government, police, and fire and safety, volunteers, faith-based communities. The more diverse the membership, the more successful they're going to be. Now, it can be a little bit of a challenge to um, to manage, but I think the results are worth it. Strong leadership, diversified funding, and having a structure that can coordinate these pieces. That's a really critical piece. Many of these sort of coalitions begin to develop informally, but to be effective, they need a structure. So Project Lazarus, as I mentioned, this is a community-based activity. And they have two basic components that are central to what they do. They have what they're calling the hub activities, and these are a community-based, bottom-up public health approach, which involves talking as widely as possible to as many groups as will listen, to build public awareness of substance use through broad education efforts and local data. Building that coalition, which does take time, but I would argue is incredibly important, bringing in that range of providers, and identify the data needs for planning and evaluation. You are not going to become all become data experts, but understanding what's out there that can tell you if it's a prevention program targeting alcohol for use by school children. How can you collect that data, and what can be done, and how do you know if you're being successful? It's always important to track progress. And then on the other hand, they outline their spoke activities, which are sort of top-down public health activities. But they can reflect based on their individual needs. Community education, provider education, hospital emergency department policies, diversion control, pain management, addressing the consequences of use and addiction treatment. And again, I think as you bring more of these folks in, each of these activities will be appropriate or should be selected based on specific needs and of the community and its own priorities, and may change over time as community education takes hold. Then maybe it's time to start working with providers. We'll talk shortly about some of the prescribing variations that we see and why that provider education is so important. Project Vision, and I had the pleasure of inviting the chief of the Rutland Police Department and some of his officers to a meeting in Portland that we heard about what they were doing, and it's really fascinating. Their goal is to empower the community and strengthen neighborhood. So they have three committees: crime and safety, substance use, and community and neighborhood housing. And this drug market intervention model, it was really very interesting. So they had whole neighborhoods where dealers were living and they were distributing heroin. The property values were declining. People were moving out. And they often didn't have the evidence to arrest anyone, but they would park a police van in front of those apartments, particularly in good weather, and just sit there all day. And folks would eventually get to know the officers, and it's really been effective in making it uncomfortable for the dealers to continue to traffic their wares, and they've moved to other communities. It's not always, and some of the pushback has been, well, if you push them out of Rutland, they might get down the road to Barry, Vermont, or somewhere else. And while that's true, it's a process of making it uncomfortable in as many places as possible. So some of the other programs that I think can be adopted in terms of education is some of the prevention, I should say, is education. There are school-based education programs, including pledge cards, that young people will pledge not to use alcohol before a certain point. Red ribbon campaigns that involve warnings not to share attached prescription, not to share dispense prescriptions. Billboards, presentations at colleges, churches, civic organizations, radio and newspaper spots. Why I think some of this broad-based education is important is, as I mentioned earlier, it's not just the children we're targeting when it comes to substance use, it's adults as well. And if we, as organizations and community leaders, don't present a message that early alcohol use is bad, and parents and others model behavior that doesn't reinforce that or doesn't take it seriously, then the community-based education is less effective. So here's some prevention models, and I can continue to look at is helping kids prosper. There's a strong African family teen program, keeping it real, and there's a modification for rural communities, outreach and services through telehealth, the Gloucester Angels program, contingency management, smoking cessation. All of these things there's a fair amount of information either through the RHI hub or links that we can send you that are worth considering. And so based on is it alcohol? Is it certain types of drugs that are a problem? Is it young pregnant women who are having difficulty? Picking a model and maintaining some fidelity to that model is critical. So let's talk a little bit, because I'm going to move now into talking about prescribing practices, and this is an area where hospitals, I think, and providers have direct control. So if you look at this map, and this came from a national prescription audit, it shows the variation in prescription of opioid painkillers across the states. And this, to me, really gets to the heart of the problem. We have the variation is 3 times in the highest states, it's 3 times the rate of the lowest states. So if you look at that middle section of the South up through the Midwest, Arkansas, Louisiana, Mississippi, Alabama, up through Michigan, the Upper Peninsula, Kentucky, West Virginia, the Carolinas, we're prescribing 3 times, the physicians are providing, and prescribers are prescribing 3 times the rate of prescriptions in those communities as in, say, New York, Vermont, Wyoming, South Dakota, Minnesota, California, Colorado. Some of that is education. There will be some that push back and say that the reason for that is that, in some of the poorer communities or in mining communities, you have a higher rate of industrial accidents and problems, but I don't think that accounts for that variation. Much of it is prescribing patterns. Now, there's a particular drug called Opana, which was associated with a wide increase in opioid, in HIV in Indiana, in Austin County. There's a 22 times difference in prescribing rates from Tennessee, which is the highest prescribing state, to Minnesota, which was the lowest prescribing state. And there's nothing that can convince me that there is any clinical justification for that variation in drugs and prescribing patterns. So we really need to focus on this issue. And this is another way of looking at the problem. So from the highest to the lowest, with the States of Alabama, West Virginia, Oklahoma, Tennessee, and Kentucky having the highest rates of opioid prescribing. New Jersey, New York, Hawaii, California, Minnesota at the lowest levels, and then variations in between. Again, just another way of looking at that prescribing problem that really argues for hospital and provider response to this issue. So the type of education we probably need are one-to-one prescriber education, continuing medical education on pain management, licensing action against criminal prescribing, and implementing and monitoring evidence-based prescribing guidelines among all providers. The CDC last year put out a series of guidelines. Some states, such as Washington, have also done that. And I highlighted this, and I think strongly probably isn't strong enough word. I hesitate to use the word mandate, but it's really necessary that we encourage and mandate the use of prescription drug monitoring programs. Every state has one now. Typically, their pharmacies report any prescription opioids, any opioid prescriptions being filled, and providers can access this information before they prescribe to a new patient. And I think this is critical that we take advantage of that opportunity. We can think about Oxy-Free emergency departments where hospitals reduce the use of OxyContin and other synthetic opioids as a first response to pain, and also include harm reduction, naloxone use, and opioid user education among physicians, hospital emergency departments, public safety officers, and our EMS agencies. So here's some of the and we'll move into a couple of models in a second, but hospital prevention strategies, really thinking about supply reduction from providers. It's, I think, incredibly important for hospitals to implement and develop provider-accepted guidelines around opioid prescribing. It's stunning to me, as much as we're aware of this problem, how much that we haven't solved it yet. So I think each hospital, looking as part of the medical staff guidelines, and with the full interaction and support of their providers, develop guidelines and implement and monitor them that they can live with. I would like to see, if it's possible, hospitals to encourage and monitor the extent to which their providers are using the PDMPs in their state. It's a huge resource, and it's not used well. Many states make it voluntary. Now, out of fairness, there are complications with using it. It slows down the providers. Ideally, if we can get far enough along with HIT, you could link the electronic health records to the PDMPs and download the information that way. But I think we're a ways from that problem. Using telehealth to adopt Project ECHO and others to support prescribing and pain management capacity. So let's talk about the Oxy-Free emergency department, because this is one I think it's very important, and probably one of the more common sites of medication shopping. If you think about it, a lot of folks who are trying to obtain illicit supplies of prescription medications, they are not likely to go to a family doctor because they're at least more aware of their patients. But they will go to the emergency department on weekends. And so it's a significant source of prescribing opioid prescriptions and drug-seeking behavior. The guidelines for the Oxy-Free ED were really first developed through a collaboration of the Washington Department of Health and the Washington chapter of the College of Emergency Physicians and the Washington Hospital Association. And basically they limited they came up with a joint process to limit the prescription of opioids in the EDs, so that they would not necessarily refill lost or stolen opioid prescriptions. If someone comes in with a bad ankle or a bad back, they were not going to be given OxyContin as the first line response. And what they found in Washington is that the initiative has helped to reduce the rate of ED emergency department visits by frequent users seeking opioid prescriptions for low acuity problems. That they saved in the first few years after the program was implemented $33.6 million in their non-managed care population from unnecessary visits and reduced prescriptions. And for the most part, the hospitals were pleased, although there was some early reductions in patient satisfaction scores related to pain management, but these can be handled with education and prior thinking. So here are some evidence-based supply programs that we should think about. So we have the Mid-Coast Maine Opioid Prescription Reduction Program. Nevada has a rural opioid overdose reversal. Mackenzie Health System in Michigan has implemented an Oxy-Free Ed, much the way we talked about earlier. And that there is a program to reduce prescribing by providing pain management services in Salem Township Hospital. So these are all programs that engage critical access hospitals, have been adopted by them, and can be adopted elsewhere. So the main Mid-Coast Maine prescription opioid prevention really targeted one source of prescription requests in their emergency department, and that's for dental pain. It's been implemented in 2 rural EDs in the state of Maine, one of which is a critical access hospital. It's driven by it was driven by the ED chairman, the department chair, with input from the physicians. And any patient who requests a refill of controlled prescriptions, has multiple controlled substance prescriptions, or have multiple previous ED visits for pain conditions are affected by this. The physicians will immediately check in their records to determine if this is the case. They'll recommend alternatives to narcotics, so nerve blocks, immobilization. And after 12 months, they found a reduction in the rate of opioid prescriptions and visits for dental pain. So it reduced unnecessary use. Nevada's Rural Opioid Overdose Program was implemented. It's a partnership that was led by Desert View Hospital, also a CAH, to improve access to naloxone and training for first responders. They distributed naloxone to EMS agencies staffed only by basic level EMTs. They allowed and facilitated distribution to at-risk individuals and family members, and provided education to prescribers and to emergency department staff, and continued public education, with the result that 117 EMTs were trained in the administration of naloxone. Naloxone is controversial with some folks, but it is a proven medication that can reverse and prevent unnecessary deaths. The Oxy-Free we've talked about. I'll skip over that. I think I may have put a few slides in by mistake, but the Mackenzie Health System began their program in February of 2013, and they discontinued dispensing narcotic and sedative medications for chronic pain. They had a 60% reduction in opioid prescription abuse within a 12-month period, and they reduced utilization of unnecessary and costly diagnostic workups. Now, as a way of being preemptive and to head off concerns and complaints about pain management strategies, they met with community mental health officials and county health officials did a lot of education with primary care providers and law enforcement about the new initiative. And it's been successful, and they've been pleased with this over time. And the process is that they do a thorough medical exam to rule out medical emergencies. They require a full review of the complete file, including the internal health records, outside records, drug screening tests. And if they present with a chronic pain or suspected narcotic abuse, they may not prescribe the narcotics. They may eliminate that, and they conduct interventions with the patient. If they do prescribe after careful review, the individual only gets a limited amount of the medication until they can be seen by his or her physician. But it's created a situation, I think, where the hospital becomes known as one that is paying attention to this issue, and it's reduced the targeting of their emergency department as a source of diverting drugs. Pain management. A lot of the prescribing problems that we have are due to the fact that there is limited pain management services in many rural communities, and as a result, they rely on prescription opioids as a primary treatment modality. Many of our rural primary care providers have limited experience with chronic pain, so the couple of the strategies I'd encourage folks to think about is either using expanded access to pain management services through contracts with telehealth, or also to increase the capacity of local providers to manage pain using programs such as Project ECHO. So here is one situation for expanded services. Salem Township Hospital in Marion, Illinois, it entered into a contract with the pain specialist who travels twice a month to treat patients. And it's been so popular that they're considering expansion to 3 to 4 times a month. Patients are seen in 1-hour increments. The specialist can do trigger point injections for long-term pain management, promotes physical therapy and alternative treatments, but also continues, works with the local physicians and patients to adhere to certain standards. So patients who are continuing with opioids must have a written agreement to regular drug testing and not ask for early refills. And out of over a 3 to 4 month period after they started this, only 3 out of their 56 patients who were on opioids prior to the availability of an alternative service continued to stay with that. And they found that their capital investment was fairly minimal, about $25,000 for capital costs. Martha's Vineyard Hospital is another rural facility that's located on Martha's Vineyard off the coast of Cape Cod. Like many island hospitals, real issues with access and travel, particularly in bad weather, getting off the island. And once you're off the island, you have a 2-hour drive to Boston. So they worked with Mass General Hospital to offer a pain service via telehealth. The Mass General providers have 3 days per month pain clinics that are done through telepain and telecommunication technology, and they also do on-site visits twice a month. So it's a program that they use a shared medical record to update and interpret results and tests. The services include initial consults and follow-ups. So the consults are often done through telepain, and the interventions for pain are done by the on-site providers. So they have a 2-part program, 3 days a month by telehealth and twice per month on-site. They use an RN who's been specifically trained in pain examination for pain and medical management, takes on the performs the patient exams using direct physician supervision, and it's a very transparent process. So as I mentioned, the physical exams are repeated on site prior to intervention, and over 13 months they had 49 patients that the study was being conducted. 49 patients participated in 238 pain clinics through televideo and 121 on-site interventions. For the patients, it reduced travel costs, improved access to care, and general satisfaction. The issue that was tricky for them is that they did, in their patient satisfaction studies, look at some of these issues and found that many of the lowest, overall they were satisfied with the service, but they found they were somewhat less satisfied with the telepain services opposed to inpatient encounters, and they thought it was harder to develop a friendly relationship with the doctor. But I think that's something you have to balance, that satisfaction with improvements in access. I mentioned Project ECHO, which is a video-based education program that many of you have heard about. The University of Washington conducts a telepain program using their own providers, and it provides a variety of didactic presentations using their pain medicine curriculum developed by the University of Washington. They have case presentations allowed by community physicians, interactive consultation, and the use of measurement-based clinical instruments to assess treatment effectiveness and outcomes. It creates a mentoring relationship, and it has improved access. It's improved the capacity of local providers to manage pain, and gives them a place to go if they find themselves stuck and they really need to get professional consultation and support. I'll move on to treatment strategies, and I'll try to wrap this up quickly in case there are questions. We should start off by really understanding, I believe, that rural residents deserve the same level of access and treatment, to the same level of access to services as a full range of substance use treatment services as urban residents. It's a chronic relapsing disease, not an acute episodic condition. And we really need to think about systems of care and how we engage this throughout the healthcare system. Less than 50% of people treatment access and completeness is a problem. Less than 50% admitted to treatment complete it. Relapsing is not uncommon. It's well known that patients will relapse multiple times as they go through their care, and many will use and relapse. 50% will relapse in the first year following, and 80% of those are within the first 90 days. So distance to services is correlated with treatment completion. The farther it is to travel, the less likely people are to complete their care. Some of the barriers to, one of the things we'll talk about is medication-assisted treatment for opioids, buprenorphine, Suboxone by its trade name. We know there's poor coverage for MAT services, that many of the opioid treatment programs in some states are cash basis only, which really limits the ability of people to participate. The services are clustered in urban communities, and we know that buprenorphine providers operate below their capacity. I won't spend much time on a system of care, but it's really important to think about how we engage and organize systems so that they work across the system of care and not as silos. And this becomes particularly important with rural communities because there's so few resources that we cannot afford to waste them. So we should think about technology as we participate with this, how we share the load and how we develop these regionalized systems of care. I'm going to move past this and get to some of the treatment activities. We mentioned screening before. Screening is, there's a program called SBIRT that is strong evidence base promoted by the Substance Abuse and Mental Health Services Administration. It's an evidence-based universal public health approach. It's a way of identifying and intervening at a primary care at a basic patient level around substance use disorders. Every patient is screened annually to assess their risk when they come into the office. At-risk individuals receive some brief interventions, and when necessary, they'll be referred to treatment. So one of the programs that I'd tell you about is in the state of Washington.